Hello guys, this is Dr. Asif. Today I'm going to discuss about a long case which is very important for final exam, that is carcinoma breast, which is very common in case of elderly female and also child nowadays is much more commoner in reproductive age. So mostly it's the disease of the elder people, but if family history positive, in that case carcinoma breast can be happen in early ages. Okay, let's start our session. So first you have to present your case within 5 to 7 minutes. That is my patient, Mr. X, 42 years old, premenopausal, normotensive, non-diabetic lady hailing from Shaltha Faridpur, presented with the complaints of swelling of right breast for 6 months, occasional pain in the right breast over the swelling for last 1 month, and according to the patient's statement, her presenting complaints started about 6 months back. Then he noticed a lump in her upper and outer quadrant of the right breast, which is gradually increasing in size, and occasionally dull aching pain over the lump for last 1 month. She didn't complain of any swelling or pain in axilla, opposite breast, or any other sides. So it is unilateral breast swelling. So there is no history of fracture or fever. Her appetite is normal and no history of weight loss. Bowel and bladder habit are normal. So she has no history of cough, hemoptysis, chest pain, bone pain, or jaundice. She has no significant past history but used to take OCP for 5 years. Mark the point. OCP is a factor for breast cancer. That's why there should be a history of OCP exposure. She is immunized. She has no history of allergy or any other drugs or foods. She is a premenopausal woman. Menarche started about 13 years. Menstrual cycle is regular. During the menstruation is 3 to 4 days. Flow is average. Last menstrual period was 14 days back. She is married for 22 years and having 2 children. All are healthy. Age of the first child 20 years and the last of age of last child 15 years. All are breastfed. There is no family history of breast disease, or on examination patient is ill looking, cooperative, mildly anemic, non-ectatic, non-dehydrated, inhalation is average. All accessible lymph nodes are not palpable. All other vitals are within normal limits. So on local examination there is a lump in upper and outer quadrant of the right breast measuring about 3 into 3 centimeter. Overlying skin is normal. Local temperature is not raised. Lump is non-tender. Surface is irregular, ill-defined margin, hard in consistency, not fixed on overlying skin or free from underlying muscles, and fascia nipple areolar complex is normal, and there is no nipple discharge and axillary lymphadenopathy. So opposite breast and axilla are normal. So you have to mention what the condition of other breast. Okay. On abdominal examination, shape of the abdomen is normal. Flank are not full. Umbilicus is centrally placed. Inverted, no inguinal vein, no visible peristalsis, hernial orifice are intact. So no organomegaly or ascites. Upper border of the liver dullness is present in the right fifth intercostal space. On the mid-clavicular line, a bowel sound is present, and digital rectal examinations reveals no abnormality. And the respiratory system and other systemic examination reveals no abnormality. Okay, that is the explanation. Now, what is your diagnosis? So carcinoma of the right breast, which is T0M0N0, it is early breast carcinoma, stage 2A. So what is the early breast cancer here? So early operable breast cancer is T2 or 1. That means stage 1 and 2, node 0 and 1 M node. So it means T1 and 2 tumor size up to the 5 centimeter. No nodal involvement or mobile ipsilateral axillary lymph node in enlargement, and no distant metastasis. Okay. So what are the other possibilities here? There should be a traumatic breast fat necrosis, fibroadenosis, phyllodes tumor, fibroadenoma, antibioma, tuberculosis. So on the other hand, traumatic fat necrosis and fibroadenoma is most common as the other possibilities, but sometimes phyllodes tumor, it is also called cystic sarcoma phyllodes. Okay, what investigations will you perform in this case? So there is series of investigations, so you have to you have to make the instrument part by part. That is, first part for diagnostic, second part for routine, and third part for fitness. Okay, so to confirm my diagnosis, I will advise mammogram of both breast and axilla, as it is a radiological examination investigations, as which is about 90-95% sensitive. So mammography should be done, and ultrasonogram of the both breast and axilla in case of young women, because the breast of young woman is densely adhered and dense breast. In that case, sometimes mammogram may causes false positive. That's why ultrasound is the best test in case of young adult. And size of the lump and any findings of the carcinoma of the breast, any focality or a multicentricity, any axillary lymphadenopathy, like mammographic findings of carcinoma is discussed later. So I will discuss it later what is the findings, but you just mention mammography and ultrasonogram of the breast in case of young female adult, and mammography for elderly age. And another things which is very important, that is FNAC or core biopsy, ultrasound, and it should be done by ultrasound guided. Okay, so ultrasound guided core biopsy for tissue diagnosis or histopathological analysis, and immunohistochemistry by receptor status. Okay, so we will send this tissue for immunohistochemistry later on. Okay, so here there is some investigation dilemma. What are these? FNAC gives false negative mainly through sampling, or invasive cancer cannot be distinguished in situ disease, because where you put the needle, there is no malignant cell, so you think it's a normal things. But in case of core biopsy, you will take a significant amount of tissue from an area, so malignant cells will must present in any segment of the tissue. That's why FNAC sometimes make a diagnostic dilemma. So a histological specimen taken by the core biopsy allows a definitive preoperative tissue diagnosis. Okay, so it differentiates between DCIS and invasive disease. It gives information about receptor status. Okay, if needed, in neoadjuvant therapy started by core biopsy information. Okay, aim of treatment or early breast cancer. What is the aim of treatment? That means the cure, likely in some patients, but late recurrence is possible. So control of local disease in the breast and axilla, and conservations of local form and functions, and prevention or delay of the occurrence of distant metastasis. Okay, so prevention of recurrence, conservation of local form or functions, control of local breast tissues, and local disease in the breast and axilla, and also likely to cure the patients as soon as possible, because if the patient comes late, that means the disease is already spread out through blood circulation. Okay, diagnosis: locally advanced breast tumor. So you how you will think it's going to happen. These are defined as a primary tumors, are then 5 centimeter in size. I already said that if the disease is if the tumor size is more within 5 centimeter, then breast conservation or BCS can be done. Or less, often the patient with bulky or fixed axillary lymph node, these patients stage 3 or 4 in 0 or 2 and MNO. Okay, what is advanced but operable disease? Advanced cancer but you can operate. Where advanced but operable breast cancer is stage 3 N1 and 2 M0. So tumor is more than 5 centimeter, yes, and but no direct extension to a chest or chest wall or skin. Okay, enlarged enlarged tumor but not involving chest wall or skin. In that case, we will regard it as a stage 3 N1 or 2. Okay, lymph node status: mobile ipsilateral lymphatic axillary lymph node or ipsilateral axillary lymph node, fixed or matted, clinically apparent ipsilateral internal mammary node in the absence of clinically evident axillary node metastasis. And also what? No distant metastasis. There is no evidence of distant metastasis. So what investigation you will do in case of advanced cancer? So I will advise the excisional biopsy for confirmations and to see extension of the disease, and I will advise chest X-ray to see any evidence of metastasis like multiple deposits, consolidations, and pleural effusion, and ultrasound guided whole abdomen, that is any liver metastasis if there is presence of any ascites, and CT chest or abdomen for better delineation. And bone scan, we know that breast cancer is a osteolytic lesion happens in these bones, so it spread to the bone. Most common bone tumor which comes from any metastatic disease, that is in first, that is 21% according to the Bailey lab, that is breast. Okay, so bone scan and other investigations for general conditions confirm the my diagnosis. So what is the treatment of locally advanced inoperable breast cancer? What you will do if the advanced cancer and also is inoperable? In that case, locally advanced inoperable breast cancer including inflammatory breast cancer, which is very extensive high grade tumor, the and which is I saw in my training period 1 and 2 patients, and they are very young ages, and the breast becomes swollen and up to the axilla and hand also. So inflammatory lesion occurs not only in the breast but also in the skin or surrounding structures. Usually treated with systemic therapy, either chemotherapy or hormone therapy, occasionally toilet mastectomy or radical mastectomy, or radiotherapy is required to control the fungating tumor. Okay, now treatment options for carcinoma breast. What are the treatment options? Treatment of carcinoma breast including treatment of breast itself, treatment of axilla, treatment of metastatic site which can be done by surgery, radiotherapy, chemotherapy, hormone therapy, immunotherapy, and tumor lymph nodes, excision therapy. Treatment adjuvant for breast treatment of depends on staging, grading of the patient preference. Okay, so you must perform staging of the patient first, then you will go for planning, that all the multidisciplinary team approach. You can perform, you can make arrange a tumor board meeting where you will arrange you will advise taken from oncology department, radiology department, and also respiratory, cardiovascular, and also surgery. So a multidisciplinary team should be done to form a tumor board and make a decisions and make a staging, what operations or what steps a surgeon should go, and what are the treatment protocol. So they will arrange here by a meeting. So you have to mention that multidisciplinary team, and you have to counsel the patient party about the treatment protocol and treatment staging and cost, and where it is available, and the timing of the treatment, because these malignancy cases, in not only this breast cancer but also any malignancies, all the disease has their golden period of time for treatment. If the patient comes lately, then the prognosis is questionable. In that case, patient party, not only patient but also patient party must conscious about the staging and the treatment protocol. Okay, so stage 1, tumor size less than 2 cm, clinical not palpable. For breast, 2 options: breast conservative surgery, that is BCS, followed by radiotherapy. So that is well moderately differentiated and fulfill the criteria of BCS, breast conservative surgery. Some simple mastectomy indication, patient not preferred facility, not available, does not fulfill the criteria of BCS. Available facility for sentinel lymph node biopsy, SLNB biopsy positive, then axillary dissection, then sentinel lymph node biopsy negative, then follow up. Okay, if positive SLNB, in that case axillary dissection must. Stage 3, facilitators not available for sentinel lymph node council in lymph node biopsy, then axillary sampling or positive, then axillary radiotherapy, and axillary sampling negative, then follow up. Okay, Stage 2, tumor size less than 2 cm but single, mobile or axillary lymph node. Okay, now tumor size 2 to 5 cm but clinically not palpable, lymph node. Treatment surgery followed by with or without adjuvant therapy for breast. Two options: breast conservative surgery and mastectomy. Surgery followed by radiotherapy. That means when the breast size or tumor size 2 to 5 cm but clinically not palpable lymph node, then treatment should be surgery. Patient preference for BCS, facility available, well moderately differentiated and fulfill the criteria of BCS. And secondly is simple mastectomy. For axilla, patient not prefer, facility not available, does not fulfill the criteria of BCS, single or mobile, lymph node may be positive, in that case simple mastectomy. Then axillary dissection, clinically not palpable axillary lymph node, if facility not available then sentinel lymph node biopsy, if facility not available then axillary sampling. Okay. Adjuvant therapy, that means sometimes some tumor are hormone sensitive like estrogen and progesterone positive and Herceptin negative. In that case we will go for hormone therapy like tamoxifen in case of premenopausal, and in case of postmenopausal aromatase inhibitor letrozole 2.5 is available in the market, and the lymph node positive then chemotherapy. Stage 3 locally advanced, then counsel the patient and consult with the oncologist and start neoadjuvant therapy like 6 cycle chemotherapy first done, then go for operation, because 6 cycle neoadjuvant chemotherapy is used for downstaging the tumor, then tumor is operable and we can clear the margin clearance positive. In that case we will go for excision of the tumor like breast conservative surgery or modified radical mastectomy. And stage 4 counsel the systemic treatment like bony, lung, liver involvement. In that case adjuvant chemotherapy is the treatment of choice. Now in case of stage 4 treatment, that is distant metastasis, where they counsel the patient and consult with the oncologist, then systemic therapy, chemotherapy, hormone therapy and the treatment of metastatic sites. Treatment of metastasis, what you should do, it is a palliative care. If bony metastasis, then radiotherapy and fixation of previous fracture if associated with pathological fracture like Pott's disease or osteolytic lesions due to tumor metastasis. We can give steroid, bisphosphonates therapy, NSAIDs and a treatment of hypercalcemia. If the lung metastasis is present, then steroid, bronchodilator and pleural fluid aspiration. If the liver metastasis is present, then chemotherapy. If brain metastasis, then steroid and radiotherapy. Here so what is the role of brain metastasis steroid? Because steroid decrease the edema, surrounding edema, which will decrease the intracranial pressure and reduce the symptom like headache, like raised intracranial pressure will be reduced by steroid, or it also gives some anti-inflammatory effect. And also radiotherapy you must give. Now what are the surgical options of invasive breast carcinoma? That is invasive ductal cell carcinoma is most common in our country. So what are the treatment options in this case? There are 3 established surgical procedures for invasive breast cancer: wide local excision, quadrinectomy or segmentectomy, and mastectomy. It could be simple mastectomy or modified radical mastectomy. Both wide local excision and segmentectomy would normally be followed by radiotherapy. Now what are the factors influencing the choice of breast conservation? What are the factors? The ratio, the size of tumor to the size of the breast. Smaller tumor in larger breast are more suitable for breast conservation, but larger tumor in small breast, a cut of 4 cm of the tumor is often quoted. The pathological when you have a large breast but small tumor like within 4 cm, that means we can perform BCS. But if the tumor base is small but tumor is large, but whatever it is 4 cm or not, you should go for mastectomy. The pathological features of tumor, if extensive in situ, histological grade 2 or 3, lymphatic or vascular invasion present or not. There is increased risk of local recurrence if disease is invasive or ductal cell carcinoma. It is less than 1 millimeter from the margin clearance excisions or presence in multiple sites. So you must perform mastectomy or excision and less than 1 millimeter. You have to clear the margin with normal tissue. And the age of the patient ages less than 35 years are at increased risk of local recurrence. And the patient's own preference, fitness for the surgery and or radiotherapy. So what are the indications of mastectomy here? It's a question. What is the indications? Large tumor, multifocal disease, local recurrence, patient's preference, and central tumor beneath the involved in the nipple. Because when nipple is involved, that means it's a invasive tumor. So you have to make a mastectomy along with your nipple, areola, everything. Okay. So it's indications whether a patient has breast along with nipple or areola involvement, in that case mastectomy. Or if the patient has both nipple or areola present but tumor is not present, in that case it is BCS. Okay. So large tumor, multifocal disease, local recurrence, patient's preference, and central tumor beneath the nipple and areola. Okay. Now some terms in the breast malignancy you will encounter in your practicing life. That is segmentectomy means segmental excision of 1 centimeter macroscopic clearance of both invasive and in situ disease. Wide local excision, what it is? Wide local excision tumor with margin of clearance of both invasive in situ disease. And quadrinectomy, that means similar excisions to segmental excision but with 2 to 3 centimeter macroscopic margin clearance. And breast conserving surgery, the combination of wide local excisions or segmentectomy and radiotherapy is often breast conservation. Quad therapy, it is quadrinectomy, axillary dissection of level 1 and 2 nodes with separate axillary excision, and postoperative radiotherapy of 2 breast and axilla. So what is simple mastectomy? You all know about the simple mastectomy because it is invariably practiced in everywhere, not only central but also in the peripheral hospitals. That is, simple mastectomy involves removal of only the breast with no dissection of axilla. Okay, there is no dissection of axilla, only breast, except for the region of the axillary tail of the breast along with axillary tail, which is usually attached to it a few nodes low in the anterior edge group. And modified radical mastectomy or Pettis mastectomy, in the breast associated structure are dissected in block and excess mass is composed of. So modified radical mastectomy, that means en bloc excisions of something, that is whole breast, large portion of the skin of the center of which overlies a tumor but which always including the nipple, in the fat, fascia, lymph node and axilla, but not in the pectoralis major muscle and bones. Okay. What do you mean by axillary sampling? So sometimes you will take during quadrinectomy and axillary sampling. How? What is sampling? So axillary sampling is done by separate carved incision between the outer border of the pectoralis major and latissimus dorsi 6 cm below the apex of the axilla. About 10 to 15 nodes level 1 are sampled. Aim is to remove the largest node in the axilla which are likely to be involved. At least 4 lymph nodes should be removed. At least 4 lymph nodes should be removed and all 4 should be sent for histopathology. So when you will dissect level 1, so you will try to take 10 to 15 lymph node and at least 4 out of them should be malignant. In that case it is regarded as axillary sampling positive. Okay. So axillary sampling is done separate curve like level 1, 2 and 3. You must know anatomically what are the nodes, 3 nodes present in where, like behind the pectoralis minor muscle, just behind the pectoralis major muscle, and lateral to the axillary vein, So you must know the groups of axillary lymph node. What are the complications of axillary clearance? After the axillary clearance, what are the complications should arise? That is seroma formation, infection, lymphatic cutaneous nerve damage, because there are many nerves present go through this. So some nerves may be sacrificed. Shoulder stiffness, pain, long-term complication like upper limb lymphadenopathy, neural damage, and restricted shoulder movement. These are the most common post axillary dissection complications. So how will you follow up the patient? It's a big issue, because you have been treated the patient and the patient go for chemotherapy, and after that patient again came to you for follow up. So what are the points you will give more focused for follow up points? That is no specific follow up schedule. There is no specific, varies from center to center. Follow up should be done, yes, according to the stage of the disease. Aim of follow up is to detect local recurrence when treatable or contralateral disease. In established metastatic disease or uncontrolled local disease, follow up should be done for disease progression and their needs. Patient should be followed up by history, clinical examinations and investigations like hematological and biochemical, USG and or mammography, CT scan. Again you will do again all the investigation for diagnosis, so you have to repeat it for follow up, that there is a pre-existing malignancy or again recurrence of the disease happens or not. So you will give these things, hematological like CBC, serum electrolyte, serum creatinine, and some so like 15-3 tumor markers. You can go for that, CA15-3, and USG, mammography, CT scan, okay, MRI if needed, because MRI is sensitive for recurrent breast cancer. When you have make a mastectomy, or mastectomy happens in anywhere and there is again a tumor or swelling, so which test is the best in this case? So MRI is the best, okay. So you have to say MRI for recurrent breast disease, okay. So how patient come for follow up, that is 3 monthly, then 1 year, after 1 year 6 monthly, then 2 to 3 years yearly one time, and up to the 10 years. So it is disease free, okay. Now the prognostic factor for carcinoma breast. What are the prognostic factor? Prognostic factor for breast carcinoma, like patient factor, age, younger age group, worse prognosis. In case of male sex, worse prognosis, because male who has gynecomastia and also BRCA1 positive and who have very aggressive high grade tumor happen in the case of carcinoma breast. Tumor size measured histological larger size means worse prognosis. And axillary node metastasis on pathology, not clinical ground, survival is directly correlated with the number of lymph nodes involved. More than 10 nodes is badly. That means lymph node on pathology, on clinical ground, survival is directly correlated with the number of lymph node. That means if more than 10 nodes are positive, in that case it is very bad. High histological grade, lymphatic or and or vascular invasion, presence of distal metastasis, and hormone receptor status, and Nottingham prognostic index. As you know, the Nottingham prognostic index is index which is from the UK protocol. So I think it is one of the ideal one by prognosis to detect any prognosis. So what is triple assessment? So in any patient who presents with a breast lump or other symptoms suspicious of carcinoma, the diagnosis should be made by a combination of clinical assessment, radiological imaging, and a tissue sample taken for either cytology or histological analysis, the called triple assessment. Its predictive value is almost 99.9%. So triple assessment is very important, because 3 tests: history, examination, clinical investigations, and also radiological investigations. So an histological analysis, that is core biopsy followed by receptor status and the grading of the tumor, that is very important, okay. Thank you very much. That is all about the long cases. I hope carcinoma of breast is a very big, huge things. So you have to go through the lecture again and again to memorize or to know what is the answer in concise manners, because your teacher can make you puzzled or make you thrived in your exam by a single topic, that is breast. So you have to be very cautious of giving answers in front, because it's the one things by which you can make a jackpot, like pass or fail. Thank you very much, and keep like and subscribe my channel, and keep watching my videos, and like and give me much more encouragement for future video making. Thank you very much. Peace.